I can see where subacromial pain syndrome does make sense. I think it's not as intuitive, right?
I agree with you. I'm not ready to throw away impingement as long as we have a caveat and understanding what it actually means.
There is some form of inflammatory pathology in or around the subacromial space.
I think the beef people have is that the old model of impingement syndrome is a narrow space caused the problem.
It's like, no, that's not the problem. Like, yeah, but it still kind of explains it. Like, I don't know the person who made up impingement syndrome.
Welcome to the Shoulder Blueprint, the podcast built to help you understand the shoulder, how it works, why it hurts, and how to fix it. Here are your hosts, Dr. Caleb Davis and Dr. Justin Givens.
Hey, everybody. Welcome back to the Shoulder Blueprint podcast. Welcome back, Dr. Givens, my co-host. Thank you for being here.
Thanks for having me again.
Not sick of it yet, are you?
No, I'm not sick of it. I could talk about shoulders all day.
I know you could. And we probably will today. We are talking about impingement today. And I feel like we are already starting off controversial just by using that word.
Oh, my goodness.
Shoulder impingement. Now, Dr. Givens does not spend as much time on Instagram and TikTok as I do, and he's a much smarter man and better man for it. But I have gone deep into the subterranean spaces of the internet and seen all these different people argue about impingement syndrome and subacromial pain syndrome, and that impingement's a bad topic and you shouldn't call it that, and it's incorrectly labeled. We're going to get into all that today. Impingement historically was sort of a model to describe a tight space between the acromion and the humeral head. People had bursitis, tendinitis of the rotator cuff. When you bring your arm up, you start having pain. It was more of this mechanical model of there's a tight space, it gets tighter as you bring up your arm, it causes pain. You know, kind of a simplistic model. Intuitive, though. It kind of makes sense.
Yeah, and it kind of made sense.
So let's just go ahead and dive right into that. I think impingement is a diagnosis code that we still use in medicine, too.
Regularly.
Even if you may think that it's outdated, I am not going to say it's a useless term. I'm not ready to go that far as some people are. Yeah. But we will go into some of the nuance of it. So if I use the word impingement, what I mean is when you bring up your arm to the front, to the side, maybe some external rotation up in abduction, you have pain, but you don't necessarily have a rotator cuff. That's probably the broadest way I could say it. What about
I use it kind of as a blanket term, that there is some form of inflammatory pathology in or around the subacromial space. And that classically relates to what we, call impingement syndrome or shoulder impingement or whatever it may be.
And I think the beef people have is that the old model of impingement syndrome is a narrow space caused the problem. If you didn't have that narrow space, you wouldn't have the problem. And that there have been multiple studies to show that people with narrow subacromial space don't necessarily have this problem.
Yeah.
And so they two don't necessarily correlate.
But I think it still does make sense a little bit because it is the narrowing of the space that causes the symptoms. Like patients that have, whether you want to call it impingement or subacromial pain syndrome, they don't have pain that much with their arm at their side. When you do the maneuvers that we'll talk about for physical exam, the whole goal is to narrow the space and pinch those structures. And if they're inflamed and pain generating, they will recreate the pain. So that it is that impingement or pinching motion that causes the reproduction of pain. So maybe it's not the cause of it, but it helps us to find the actual physical production of the pain and how we're going to diagnose it, I think.
And if you couldn't predict it, of course, I agree with Dr. Givens. I couldn't. You said it perfectly. I think it would be wrong to say, oh, because you have a narrow subacromial space, this is why you have your problems. But it is impingement. As you bring your arm up, the tissues are getting pinched in a tighter space, and it causes pain. So I'm not ready to just ditch the impingement syndrome name as long as we have an understanding of what we're talking about.
Yep.
I agree with the people who hate on the word that, yes, the normal anatomy doesn't cause the bursitis and the tendinitis.
I feel like it's almost, why am I blanking on these words? Oh, it's like we're trying to be politically correct for shoulder impingement.
Right.
It's like, no, that's not the problem. Like, yeah, but it still kind of explains it. Like, I don't know the person who made up impingement syndrome. Do you know who made up the term?
I think it might have been Near.
Was it Near?
Yeah, I think it was Near.
I mean, I would love to ask him, like, did you mean this because these people have narrow spaces, or did you mean this because it caused symptoms whenever you did motions that caused the space too narrow?
Right.
There.
I think the reason it's so sensitive is though because people said, okay, you have pain, you have a narrow space, we're going to do a subacromial decompression. We're going to go in with this. We're going to go and shave away the bone and make more space. And there were multiple studies that looked at people who had impingement syndrome. They either had therapy or sham surgery. I don't know if they did a sham surgery study, but they had therapy or they had surgery, and the outcomes were pretty much equivalent.
Yeah.
And so that's why it became sort of a controversial topic.
Yeah, you do a blanket surgery for the same thing over and over, trying to make it up as an excuse. And yeah, I guess I could see that, where we know that happens, right? We talked about this last episode. Oh, you have this problem, it gets treated with this surgery. Everyone is the same, gets treated the same. Nothing's individualized to people and their symptoms. That's when we have problems, right? That's when people get surgeries that don't really help, or they get surgeries that incompletely help, or things like that.
And the AC joint, like we talked about last episode, is the same way, right?
Yeah.
Just because you have positive findings on x-ray that you have AC to arthritis doesn't mean you're going to have pain, and it doesn't mean you need surgery. Yep. It's nuanced. It's a nuanced approach.
And I guess that's what's different, right? We're thinking about it differently. So like that's how I treat impingement. Everyone doesn't need a subacromial decompression, but that goes against what maybe some of the people before us were taught and what some of them taught us.
Yeah. I think the number of subacromial decompressions done in the United States has dropped dramatically in isolation.
Yeah.
A lot of people still do subacromial decompressions when, say, doing a rotator cuff surgery, just to make more room in the shoulder while they're working. Some people argue that making the bone bleed,
it's your own little PRP too.
Brings PRP, like healing factors. It's not technically PRP, but it brings healing factors to the shoulder to help induce healing of the rotator cuff repair. So, and I think that there's some sound logic to that.
Sorry, we started running way into this before we really got going. But that all started from the impingement discussion.
No, that's okay. This episode's going to be a little bit more of you and I rambling, which, well, how's that different from any episode?
That's pretty much what we do.
I would describe it more as bursitis and tendinitis. So when I talk about the term impingement with my patients, I'm like, if you don't have a cuff tear, you've got normal strength, you've got this pain, you probably have a combination of your rotator cuff tendon is inflamed, and then the bursal tissue between the acromion and the tendon is inflamed, leading to bursitis. I think it's probably the most simple way to describe it. The question is, how do we get rid of it?
Yeah, I mean, I'm with you. So I normally tell my patients, you might have heard it called impingement syndrome, bursitis, tendinitis. They're all the same, But how do you get rid of them? Well, we always have to go to our staple. We mention it every episode. If you have good scapular motion and good scapular strength, so doing your physical therapy and having good motion overall is very important. These physical therapists are going to love us when we're done with this. But then we go into other things. So this is another inflammatory condition. So, and that's, I think, where the way we look at it maybe differs from the way that some people classically thought of impingement syndrome, was that they blamed it as a structural problem.
Right.
And so since it's an inflammatory condition, we go back to all the things we've talked about for other inflammatory conditions. You can do things like oral anti-inflammatories and oral steroids. We can do steroid injections. You can do PRP injections. There's a couple different options is the way we go. I always look at the other factors, right? I'm going to try to avoid NSAIDs and things like that in patients with heart problems and kidney problems. I'm going to try to avoid steroids in patients who are diabetics. Much more likely to do an injection if someone has problems that make me worried about systemic medicines. What about you?
As you may have come to suspect at this point, my treatments are largely the same. I am a big pusher of therapy. And again, there's just a lot of resistance. People are like, well, my shoulder hurts. How am I going to go do therapy? Yeah. And true, fair, that's a fair point. But again, that's a lot of times where the steroid shots help. It makes them so they can go tolerate therapy. Yeah. I just have to warn my patients, like, look, you can't just get a shot every 6 weeks, though. That's you can't do that. You're gonna have detrimental effects from that.
Have you ever done PRP for one?
I have never done PRP for bursitis. Have you?
Yeah, I had a couple patients that had just really resistant bursitis, but they had really significant diabetes. And I was afraid the steroid was going to really push them over the edge, but they couldn't really tolerate therapy. I was very careful to make sure they did not have adhesive capsulitis, as we talked about, because that could be a reason they're not getting better, right?
Sure. But as long as their passive range of motion is normal,
range of motion is normal.
They probably don't have adhesive capsulitis.
Now in impingement, I sometimes will have people who their passive forward elevation and abduction might not be normal because they stop me because of pain.
They're guarding.
Yeah, they're guarding. Yeah. But it is out of pocket. That's the hard part. But they had been struggling with it for a while, and so I was like, hey, let's give it a shot and try PRP. is that what cured them? I don't know. Like it wasn't like PRP doesn't typically respond as quickly as steroid with decreasing the inflammatory burden. And so it's hard to tell, but they eventually started getting better after they were having some resistance to therapy before that because they just couldn't tolerate it. So, I think it's an option. I don't love it. It's not something I want to just say, hey, let's do that. But it's another option, right?
Yeah, it's another option. My biggest beef with PRP, and I'll give the same warning to everybody, is like the data's mixed.
Yeah.
And again, if people are in different economic classes,
yeah.
For some people, shelling out $500-600 is not a big deal. Other people, that's a lot of money.
Yeah.
And so I will just never push it hard because I'm like, well, it could work. So that's kind of where I'm at. Do you think that's fair?
No, I think that's completely fair. I mean, this is, another one. I had patients ask about this before, the laser stuff. I've had people ask me and I'm like, hey, I don't know. I don't have any specific data. I definitely don't think for arthritis, it makes sense. It's more of a soft tissue. But some patients are like, oh, can I try that? And I'm like, absolutely. It's just, I don't know. I don't have third-party research to say, boom, here it is. This is how well it works. And it's all out of pocket.
He's talking about topical laser therapy where they're applying a laser to painful areas of the body that are supposed to help reduce pain.
Yep.
Yeah, that's the same. There's some data coming out that's moderate for it. I have nothing against it, but anytime there's going to cost my patient something a lot of money, I better be darn sure it's going to help them, or I'm not going to be able to give them a strong recommendation to it.
And that's the thing for me. It's like, okay, I have to play the in between here, right? I have to weigh, these are the things that we have a ton of medical data on. These are the things that have low risk, but we don't have medical data on, but you'll have a big financial hit on. And, all I can do is really give you the information and then kind of let you go from there and make the decision that works best for you. For some people, like you said, $600 and 8 trips to get laser therapy is not something they can do. Others are like, hey, I'm totally down for trying that, and it's a person by person thing. And that's where, full transparency, I think a lot of the mental side comes into it. If you really believe it's going to work, it's going to have a better effect on you than someone who's a skeptic.
There's something to be said about that. I definitely believe that. And if you're investing a lot of money in it,
ding, ding, ding.
You maybe believe that it's going to work. And I'm not making fun of them. If it works for you, that's great. In terms of when do you get an MRI? So let's say the patient comes in, they've got pain when they lift up their arm to the side, to the front, their strength's normal, their passive motion is normal. Do you jump to get an MRI right away? No, I don't either.
Absolutely not.
If they don't have any concerning signs for a rotator cuff tear or some other, or labral tear that I think could cause significant problems, I will usually treat them with a presumptive diagnosis of quote unquote impingement. Yep. Call it whatever you want, and I'll do everything we've talked about at this point.
Yeah.
When do you get the MRI?
So normally I get the MRI if you've went over 6 months with a failure to respond to anything. So six plus months of symptoms. You've tried therapy and failed. You've tried injections and failed. Or one I've actually seen a couple of times lately is if you have any form of glenoid dysplasia.
Okay.
So I've seen a couple patients lately who I get x-rays on everyone when you come in the office. I will not see you for your shoulder without an x-ray because you could have a fracture, or you could have anything going on, or we could be blaming something on one thing and you've got terrible arthritis. But I've seen a couple patients lately that have pretty severe dysplasia, and you're looking at them like nothing is normal. And I think that makes it really hard then to give them a normal diagnosis, right?
Yep.
And so I've been a little more aggressive with getting an earlier MRI if they don't improve somewhat early, especially if they came in with even a minor trauma, because it's like, what level of major was that trauma? I think it's a little harder for me to just say, you know what, I'm okay with not having more information because we know they don't fit any of the norms.
Right.
Whenever you start talking about someone whose glenoid is inclined or facing up 20 degrees, and that's the way they were born and their head is proximal, and it's the same on both sides, I know that may be normal for them, but I don't know what their normal really is without getting a more in-depth look.
And there's probably not data or papers that represent that person.
There's not, and that's why I kind of dig for a little more inflammation. Yeah, they have inflammation. I dig for a little more information before I'm willing to like, okay, I feel comfortable with this being a good path for you. So
okay, so we've sort of determined that a narrow subacromial space doesn't necessarily cause impingement. How about slope of the acromion? We talk about hooked acromions. type 1, type 2, type 3. I'll put a graphic up for that so people can show what I'm talking about.
Yeah.
The acromion can be a type 1 where it's just a nice smooth, like sort of diagonal line, or they can kind of sharply hook down in the back. And some people believe that maybe that would make you more prone to impingement or rotator cuff tears.
That's been the classic teaching, right? Is that it does. I don't necessarily think I'll look at it for that now. I'll look at it on every x-ray, but I'm more looking at, hey, if I have to do something, how big of an area do I need to take down to create an appropriate amount of room? If I see that and you don't have any symptoms of those things, I'm not going to pursue it aggressively. Now, if I see that and you have terrible symptoms of impingement or terrible rotator cuff problems, that's going to play a part, right? I want to make sure I address that. But I don't, I know there's some kind of mixed data on that. I mean, to my knowledge, there's not a paper that says, oh yeah, that definitely means they're going to have a rotator cuff tear or anything.
No, not to my knowledge either. It's one of those things. I don't see a lot of type 3 acromions, but I feel like when I do, it's associated with a pathology. But that's not good data.
Exactly, right? So, and I don't know, because here's the thing. How many type 3 acromions are never getting an x-ray because they don't have shoulder problems?
Of course. And there's always that concern.
Yeah.
I'm going to put my anecdotal hat on just for a second. I am sort of right now of the belief that if you've developed a bad bursitis impingement syndrome and you have a really tight subacromial space in a type 3 acromion, maybe you're more prone to recovering more slowly from it. Whereas it maybe didn't cause the problem. Maybe it was whatever, your scapular mechanics, overload, whatever it is. But maybe because you have a tighter space, maybe it is a little bit harder for you to recover from it now.
So
can't prove that, just kind of a theory.
All right, I'm gonna go two directions with you. First, I'm going to say I completely agree. And second, I'm going to contradict us both and say that's probably why people are saying you should call it subacromial pain syndrome and not impingement. Because some of that name implies that, right? To an extent, because that's how we were all classically told. And it's like, yes, even those of us who are looking at that going, I don't agree with that. There is still some bias from our training and things like that that's like, but man, I was told that by so many people that I trusted and really got me here that maybe there's a little truth to it.
Right.
Because you look at it, a lot of what we do in medicine is a little anecdotal and based on, we try to look at research on this, but there's not a huge majority of research on every single thing we do. I mean, shoulder replacements have been around for 20 years and look at all the crazy stuff we do with them. We don't know.
Yep.
And so then you start talking about these things. It's like, wow, it's really hard to not trust someone who's been doing this for 20 plus years and they see really good success with that and the people they do it with, to not think about it in similar ways.
Surgery is an art and a science.
Yeah.
So the science part comes from data. The art part comes from experience and feel and gut in a way.
Yeah.
Something maybe we don't talk about, but I think that comes into play. But again, if we're going to have a conversation with people, and we have to disclose that. We have to say, here's what we have data for, here's what we don't. The more honest and open and transparent we are, with the better conversations we can have.
Yeah, and I think you see it in the way things have changed. Like, I would say what I do now as far as an SAD is not what some of my mentors showed me.
Sure.
I'm doing more of like a co-planing. I'm just leveling it off to make it a little flatter as opposed to like the huge block resections that used to be done. And so like when we're in surgery, you're looking at the acromion and sometimes people would just take a big flat block. I mean, we kind of have the width of the burr to tell us how much we're taking. And it was like, you're going to take a 2 millimeter block or whatever. Whereas I'm kind of zooming back and looking at the whole acromion and saying, hey, I'm just going to skim this off until it matches the shape of the rest of the acromion. I'm not just taking off a specific block through it. And so I think you see some of us progressing in different ways. I don't think you do anywhere near as big as of an SAD as some of the people we may have worked with through training.
Certainly not.
But you kind of realize, hey, I know I've still got some of that inherent bias probably that throughout the time, but like there's probably some truth to what they saw and what they did too.
And there's going to be bias in both directions. The surgeons are going to be a little bit more biased to surgery, and the physical therapists are going to be definitely more biased towards non-surgery.
Yeah,
that's just the way it is. And no hate to my therapists. I love my therapy bros and brothers and sisters in the physical therapy world.
There you go. Good job.
Yeah, being politically correct. So that's just the way it is, and we all have to just guard ourselves from that. But that's enough for Philosopher's Corner. I want to go back to, we talked about getting an MRI. I agree that if you've got no weaknesses, no concerns for other pathologies, it's not wrong to not get an MRI for a while. Yep. Although sometimes patients will push back on you. They want the MRI.
Yeah.
Like, I want to know what's going on. It's like, well, it's a waste of your money, and and your insurance probably won't pay for it until we fail physical therapy.
Well, so I think that's the easy part of the discussion. I think the harder part of the discussion starts with who normally has these symptoms, and it's patients who are in their 50s and 60s. Who normally has partial thickness rotator cuff tears already?
That's where it gets real tricky, because if you then get the MRI and the radiology report says, oh, high-grade partial thickness tears, like, well, need surgery. It's like, I don't think surgery is going to help you. Your function's normal. You just have pain. Yep. You know, that's where it gets real tricky.
And this is the discussion I have. So I tell all of my patients that I get an MRI, if you are 60 or older, there is a 50% or greater chance that you have some form of rotator cuff tear on your MRI, even if you've never had pain in your shoulder. And so if that's the case, you need to be expecting there to be a rotator cuff tear read on your MRI. Let me be the one that translates that to you, because there are multiple types of rotator cuff tears. Let me break it down so that when you see that, you don't immediately go into freak out mode. Let me explain what type it is, because not all of them need surgery. A lot of them are a normal part of aging. So that's where, for me, in impingement especially, if there's no rotator cuff weakness, no rotator cuff symptoms, from a mental standpoint, it's easier to not get the MRI. That way they're not kicking through their head, oh, I've got a rotator cuff tear. Because if you have a little 5% interstitial tear of your rotator cuff, that's not causing those significant symptoms.
Yeah.
But if it gets in your head, it might be in your head.
Yeah. You know, one of the things I've learned the most about going in the depths of the online world, like I go on Reddit now.
Oh my gosh.
Terrible idea, by the way. People post their MRI reports all over Reddit. They're like, am I screwed? Like, what's wrong with my shoulder? It'll say interstitial tear of the subscapularis. So I'm like, and I don't comment. I'm like, dude, you're fine. But they're just so freaked out about their MRI report.
You should just start commenting. You should listen to the shoulder blueprint. This is explained in the shoulder blueprint.
See, I would do that, except there's rules about self-promotion. So they're actually pretty strict about that stuff. You just spam your own content. They don't like that.
Really?
Yeah.
So you can give people totally false medical advice, but you can't self-promote? What in the world is Reddit? This is crazy.
True story. Okay. I went on the frozen shoulder subreddit, because yes, there is one. I messaged the moderator, because there's moderators of these subreddits, and I said, hey, I'm a doctor. I do this educational podcast. I'd love to share my content, but I wanted to ask you first before I promote it, because I don't want to break any rules. She banned me. I don't know if it was a she. It could have been a he. I don't know. Male or female, they banned me.
Was her name Karen? Is that why you immediately assumed it was a she? She went full Karen mode and banned me. I'm sorry, every Karen that listens to this, we really like you. It's those other Karens we don't like.
I do not know the gender of this moderator. That showed my bias right there. And I messaged her back. I was like, why'd you ban me? She said, well, you have MD in your name, and we don't want any medical advice. I'm like, okay.
We want to talk about a medical problem, but we don't want any medical advice. Wow.
Yeah. That was my experience on Reddit. I was like, okay, maybe I should just not do anything.
Look, guys, this shows you why you need to go to a doctor to get your medical advice, not some subreddit or some dumb podcast by two guys that say they're doctors. You should go to real doctors for your medical advice.
This podcast is purely for education and a little bit of entertainment. But yeah, and it's also just because we enjoy doing it.
Yeah, I think so. Yeah, I mean, all 12 people that are listening to us right now are probably like, wow, I wonder how many people listen to this. I mean, my mom, my grandma, they don't know how to use Spotify, so probably
Actually, what I would love everyone to do is go to the subreddit Frozen Shoulder and say, you should listen to the Shoulder Blueprint.
Hey, there's a great podcast about this. They're all going to get banned, and then none of them are going to learn any bad information about frozen shoulder. It'd be perfect.
It's not self-promoting, though.
Huh? That's true. It's not.
Yeah.
But now that moderator Karen, she's got her eyes out looking for stuff about you now, so she's gonna be ready.
Oh man. Well, they know who I am. They can look me up, so I could be in trouble. All right, that was another big tangent there. In general, how often would you say you're having to operate on someone with isolated impingement or subacromial pain syndrome? I mean, almost never. And it's very uncommon.
I was going to say, I think this is another hard one, because this goes back to everything else we've talked about in the last few episodes of bicep and acromion.
Right.
I'm not going in and operating on people for subacromial pain syndrome. But when people get subacromial pain syndrome and biceps tendinitis and AC pathology, and they've failed therapy and they've failed injections, they've had pain for 6 or 9 months or a year, then yes, like we go in and do surgery. I mean, I do I don't know, probably 20 or 30% of my scopes. That's not a big portion of my surgery, but my shoulder scopes, which are about half my surgeries, I'd say 70% are rotator cuff repairs, 75%. And then you got like 20% that are like cleanup scopes is what I call them.
Yeah.
But it's for multiple things, not just for one.
That's a great point. It's not. I think that's where this sort of, it's a straw man in some ways.
Yeah.
It's like, oh, orthopedic surgeon just goes in and does a subacromial decompression. That's it. That's for impingement.
I've never done that.
I don't think I've ever done that in my life.
Yeah.
But you're right. You're like, okay, at this point, we've attempted 6 to 9 months of non-operative treatment and they're still miserable.
Yeah.
Maybe you have some undersurface of the articular cuff tearing. Maybe you have some degenerative labral tearing. Maybe you have even some slap pathology that's contributing to all this, and you go and address multiple things.
Yeah, I think that's the hard part, right? Like, do I do subacromial decompressions? Yeah, do a lot of them, but none of them are just for subacromial pain syndrome. Therefore, a constellation of things and part of a bigger surgery because, like we talked about, well, I have subacromial pain syndrome, and then I start moving my arm weird, and then I get AC arthritis, or my AC pathology gets flared up. And then I'm moving that and I start to compensate and now my biceps getting flared up. And then they've injected me and I've done therapy, but all of this stuff still hurts and I'm miserable. Please do something, doc.
Yeah.
That's kind of the path of it.
No, I agree. I think that sums it up really well. And I think that's the nuanced conversation we don't always have.
Yeah.
Is there anything else you want to add to this topic?
No, I think it's a hard topic, right? And I think we talk about it. I can see where subacromial pain syndrome does make sense. I think it's not as intuitive, right? Mm-hmm. This is some pain due to some inflammatory something under the acromion.
Yeah.
But, I think impingement talks about more the way we recreate the symptoms.
Yeah.
Because if you raise your arm up and you close that space down and you have no pain and that's not what's causing it, then I'm looking at neck. I'm looking at other pathologies, right?
Right.
But yeah, I don't know that I'm down for the whole, like, we should burn it to the ground and start over with a new name. Like, I think as long as you take an understanding of, just like anything else, if we take an understanding of the condition and the pathology and how to really take care of it, we understand that the name is just a name.
And take time to explain to the patient that it's not because they have a tight shoulder that this is happening. That if you fix that tight shoulder, it'll go away. Yeah. It comes down to education and communication.
Yeah,
but I agree with you. I'm not ready to throw away impingement as long as we have a caveat and understanding what it actually means.
Yeah.
I hope everyone enjoyed that conversation on impingement, especially the physical therapists. This one's for you all. Feel free to leave your comments and reach out to us on other topics. Next episode, we're going to have retired Major League Baseball pitcher Josh Fogg on the podcast. We're going to talk about some of his experiences training, growing up, some injuries he's dealt with. So if you want to look him up and look forward to that episode. I would also really appreciate if people could give us a 5-star rating on Apple Podcasts, Spotify, like and subscribe everywhere. Helps our reach and get a little bit more engagement since I can't get any traction on Reddit.
Yeah, I know, man. And since I don't really go on Reddit, so I don't really know how to get traction on there. But apparently I can't, so I don't need to add that one to the list.
You're not missing anything.
Oh, okay, good.
Well, I'm glad that we could demystify impingement for you, and we'll see you next week.
Did we really demystify it?
I'm more confused than ever.
Yeah, okay, good. I was just making sure. I was floating out in space here, and I'm like, I don't know. Do we know anything more now or not? So, okay. No. I'm just glad. I'm making sure that we let the listeners know we're all on the same page.
No, we're all on the same page. We'll see you next week, guys. If you have any questions or want to reach out, our email address is info@calebdavismd.com. Follow me on Instagram, X, and TikTok @CalebDavisMD. And subscribe to our YouTube channel, Caleb Davis-MD. You can also follow Dr. Justin Givens @Givens Shoulder Elbow and check out our podcast Instagram page @Shoulder Blueprint. And if you haven't yet, explore my other podcast, The Wellness Blueprint with Dr. Caleb Davis. Thanks for listening, and we'll see you next time.
The views and opinions expressed on this podcast are entirely our own. They do not represent the views of our employers or any professional organizations we're affiliated with. Nothing you hear on this podcast should be taken as medical advice. This content is for educational and informational purposes only. If you have a medical concern or health problem, please consult a qualified physician.